So since you've started recording, should I go ahead and start with some of the introductions? Lindsay, or should we wait just a little bit still?
I say we go ahead and get started.
Now that I am sharing, let's see if I can pause that. Okay. Well, thank you everyone for joining us today. I am Andrea Ray from United Healthcare, and in collaboration with all the other MCOs, we are bringing you this training on integration of substance use disorder in whole person care. And I'm proud to welcome our presenters. I'm going to list them all for this morning, and then each of them is going to give you a little bit more about them as they present. So first we have Dr. Mark Duncan, and he is an assistant professor at the University of Washington. We have with us today Peninsula Community Health Services. We have Bergen Stark, who's the Director of Behavioral Health. Yes, and then we have Angie Bland, who is the Integrated Care Program Coordinator. Welcome. And then we have Albert Carbo, and he is a clinical pharmacist there. So these will be our presenters. First up is Dr. Mark Duncan. So thank you, Dr. Duncan, for joining us.
You're welcome, Andrea, and thank you all for joining us this morning. It's good to be here. So let's go to the next slide. So as Andrea was mentioning, I am an addiction psychiatrist at the University of Washington, and I do a lot of work around integrating care from a mental health and substance use disorder perspective into a lot of primary care settings. I have no disclosures, so we can go to the next slide.
Okay, thank you.
And then go to the next slide. So objectives, so I'm going to be kind of describing the need to look at integration of physical, mental, and substance use symptoms in patients. I'll be identifying some of the optimal structures around delivering integrated care across that spectrum. And then hopefully kind of work on developing some understanding around assessing the mental health symptoms within a substance use disorder context, kind of focus in on that in particular. I will say, I'm going to be kind of describing things in some broad strokes. Obviously, within each kind of clinic organization, the way this is done is going to be different based on your own resources, both from a kind of a clinical clinician standpoint, but also from a system standpoint. But these are some things that you would want to kind of think about as you're developing your program. So let's go to the next slide. All right. So this slide here is just kind of showing the overlap. And the main takeaway from this is that there's a significant overlap around mental health disorders, substance use disorders, and physical problems that people have. If you've worked in any of these areas, whether that's in a primary care setting or maybe in more of a substance use disorder treatment setting, you see that mental health symptoms are coming up. You see how substance use disorder issues are playing a role in a person's recovery. And what's, it's unfortunately over time, we've kind of developed these silos of care. And of late, things are getting better, and there is more integrated care efforts, which is fantastic. But still, there's a lot of kind of remnants of how we used to do things and how we used to kind of divvy up each of these different care issues, despite the fact that they all often are overlapping. And within the person themselves, these issues are integrated. You look at a lot of some of our efforts around treating people. It's in order for them to kind of be in recovery. They often need they may need their anxiety symptoms treated so that they can participate in a group program and that sort of thing. So there's a lot of overlap, and these are integrated in the person. And so it makes a lot of sense to kind of think, how can we bring these different interventions in these areas together to address the person as a whole, and not just, okay, I'll take care of their foot, you take care of their hand sort of thinking. Okay, next slide. So let's take a look at just how these symptoms are integrated from a mental health and withdrawal and substance use disorder perspective. On a very concrete, basic level, we see a lot of overlap in what people are experiencing. From depression, people will have dysphoric moods. In withdrawal, opioid withdrawal, they'll have a dysphoric mood and can feel depressed. In stimulant withdrawal, people are feeling very depressed. Insomnia, part of the picture, appetite issues, people can have levels of agitation across from a depression standpoint versus an opioid withdrawal, or maybe they're anxious and have opioid withdrawal symptoms, and you can see so forth. There's just that significant overlap in what the patients are physically and psychologically experiencing when they're dealing with these two separate disorders. Next slide. Okay, well, what about physical and substance use disorders? We know that substance use, there's lots of physical problems found in opioid use disorders, in particular, for example, whether that's infections such as HIV, hepatitis, syphilis, TB, or other systemic infections that people can develop related to their substance use, whether that's like an endocarditis or something. People can have bowel-related problems, hyperalgesia developing, and liver fibrosis. And it's often going to be, people are going to be in a very difficult spot for them to, again, make way on addressing these physical symptoms or physical disorders without their substance use being addressed. People are going to have difficulties making progress in their substance use disorders treatment when their physical symptoms are kind of weighing them down and not being addressed. And so again, the main point is that it's really important to think about what all is going on with the patient when you're seeing them, because it's going to impact whatever treatment efforts you're trying to kind of help them with. Okay, next slide. So now the other point that I wanted to bring up is that the symptoms overlap are very common. So it's not as if, having a patient where they only have an opioid use disorder or only have a stimulant use disorder is not all that common. It's not going to be the majority of your patients that are seeking out care. And we see this specifically around mental health disorders and OUD. So, and again, this is an example, but you'll definitely see this, whether that's within stimulant use disorders or maybe sedative use disorders, or kind of take your pick. If we look at this is from US survey data within a year. They looked at different cohorts between 2015 and 2017. And in general, what they found was that only 9% had no mental illness in the context of an opioid use disorder. People that had severe were a quarter. Any mental illness was 64%. So again, people that just have one or the other is very, very rare, uncommon, and is really not going to be the bulk of your treatment population. So it really makes a lot of sense to, again, think about what services are we able to offer people, and if we don't have those services, is there some place that we should be thinking about expanding to or partnering with an outside organization? All right, so let's take a look at the next slide. So why is this important? As I was alluding to, it's going to have an impact on your treatment efforts. So for example, again, within opioid use and opioid use disorders, opioid use is going to, just on its own, mental health disorders, just on, if we look at what does mental health disorders have on a person's risk for opioid use in general, we see there's an increased risk for opioid misuse in people with mental health disorders. It increases the risk for overdose. Again, mental health disorders increases the risk for overdose. What does the impact of mental health disorders have on opioid treatment? People are often more dissatisfied with their addiction treatment for a number of reasons. They're less likely to complete it. And there's worse treatment outcomes. People are going to be at higher risk for return to drug use, and they're going to have more symptoms of a use disorder. All right, so hopefully that's really kind of setting the stage of the importance of looking at this kind of the full spectrum of a person's health, the physical, the mental health, and the substance use, and why that's important because of its impact on treatment. So let's go to the next slide. So for this small section, the main takeaways are co-occurring disorders are common. They're going to impact the ability to treat the patient as a whole. And that the fact is unfortunately, most people do not receive adequate treatment just due to our siloed nature of care. Again, things have gotten a lot better, and maybe many of your clinical systems are working on this, or we're going to hear a little bit from PCHS about how they're doing this in particular. But this should definitely be the goal, and that co-occurring treatment is needed. Okay, let's go to the next slide. So let's talk about just a couple of strategies to keep in mind if you're thinking about really expanding into more of a kind of a whole person care approach. Next slide. So there's a few different kind of treatment models when you are thinking about treating co-occurring disorders. There's a sequential approach where you start with one thing and then you move to the other. So previously, when I remember when I first started my training, there was a lot of thinking about, okay, let's treat their substance use disorder first, and then let's see what's left over from a mental health standpoint and address that treatment. There's a parallel approach where you may have two different systems that are treating people at the same time, and then you have an integrated approach where you're going to have all of these services kind of within the same system, and there are some definite directions of where you should go. Let's go to the next slide, or the next hit. Okay, so in general, when you look at the data, you want to avoid the sequential approach. Again, when patients are presenting to you, especially around mental health disorders and certainly around physical health disorders, it's going to be a mixed presentation. Some of their issues that people are dealing with are going to be related to their mental health disorders or their substance use disorders. So just addressing things sequentially is often not going to be enough. Next point. The goal, ideally, when you look at the data, is really to kind of get to this integrated approach. Now, to be clear, not every organization is going to be able to do this. So if you can kind of trend towards that parallel direction and look at least trying to address all these issues at the same time, you're going to put the patient in a much better position to get the care they need. Okay, next slide. So what are some benefits of the integrated approach? You're going to address the whole person. We do see a reduction in hospitalization. We see a reduction in substance use severity, improves their mental health symptoms, and they actually end up having less legal involvement, which are all good things. Okay, next slide. So, what if you can't get to this fully integrated approach? Does the parallel approach have any kind of benefit? And the answer is yes, it does. So this was a retrospective chart review out of the VA, an outpatient buprenorphine clinic, looked at about 140, so not a large number. And what the two interventions were they gave buprenorphine at their outpatient buprenorphine clinic for OUD, and then they treated their PTSD, any patient with PTSD within the VA, within 3 months of starting their buprenorphine induction. And what they found is that there was a 43 greater odds of remaining in buprenorphine treatment at 6 months if patients were with PTSD, if they engaged in PTSD treatment within those first 3 months of starting buprenorphine. And that you can kind of see the 90% that were getting the trauma treatment stayed in treatment versus the ones who did not were dropping out at 24%. So you can see the real potential hazards for if you're just trying to do one or the other. Okay, next slide. If you look at integrated approach, kind of the next step from a system standpoint, the benefits are really the treatment plans that are able to kind of be coordinated. It's going to you're often easier access if you're doing this within the same system. And then it's a lot easier to coordinate meetings between mental health, substance use disorder, and physical issues. Obviously, when you're working with an outside organization, communication is harder, but not impossible. And certain organizations definitely are able to do it. But it makes it easier if you are able to do that fully integrated piece. Okay, next slide. All right, so what are some co-occurring treatment keys when you're looking at addressing their mental health or physical health in the context of like a substance use disorder? Continue to treat their substance use disorder, in particular OUD. I think that's pretty much a consensus these days. OUD treatment will improve the mood but you don't want to necessarily wait until people are sober. So we're going to talk a little bit about some of this early assessment that you'd want to think about doing to kind of suss that out as far as like, is this a substance induced or is this a mental health thing? Use of other substances is going to heavily influence anxiety, depression, insomnia. So, as you treat their OUD, also thinking about what other substances they're using is going to be important too. Okay, next slide. All right, so let's talk a little bit about just some basics around mental health assessments in substance use disorders, and then we'll transition to our co-presenters. So go to the next slide. So I'm highlighting this because this is often pretty challenging to figure out. I've been making the case that it's important to do integrated whole person care. So you're addressing both their SUD, mental health disorders, and physical health disorders. For physical health, it's obviously clear. If you see, in fact, if they have hepatitis C based on a blood test, then you treat it. If they have cellulitis from injection drug use, you treat it, endocarditis, etc. But when it comes to mental health, things can be a little bit cloudier. Now, there are some ways, if you were to roll this out into your system, there are some things that a clinician could do to kind of suss this out. So a couple of points that I want to make around distinguishing substance induced versus a mental health disorder is this. One is when you see a persistence of symptoms after their intoxication and withdrawal, and this can be for at least 4 weeks. The development of symptoms in excess of what would be expected. So if people are much more severe in their depressive symptoms, say like on a PHQ-9, versus like most other people going through your OUD clinic or SUD clinic, that would be a tip. What's their past history look like? So if they had some previous episodes of depression or anxiety issues or whatnot. What's their family history? There's a lot of people with parents in particular, siblings that have mood disorders or anxiety disorders or psychotic disorders. That's going to be a pretty significant good clue. And then, what do their abstinence periods look like? So a lot of the history can be pretty helpful. Okay, next slide. What are some questions that you're going to want to kind of look at? So first off, figuring out if they have a primary mental health disorder, looking at, do they meet the full criteria for the DSM-5 syndrome you think they may have? So do they have all of their depressive symptoms? Do they meet the criteria for mania or a generalized anxiety disorder? So making sure that they at least check off, or ADHD, making sure they at least check off those boxes is going to be a good starting point. Again, we talked about the excess of symptoms beyond the substance, so people with more severe symptoms, and then their patterns. Other historical features you're going to want to ask about is suicide attempts, developmental history potentially, family history we talked about, and then past response to treatment. So when you're starting someone out, and I would argue, you'd want to screen them for use like the PHQ-9 at that first visit that you're starting buprenorphine or doing your initial SUD assessment. You're gonna you can ask them, you could say, oh, these depressive symptoms are pretty high right now. How have you responded in the past, if they've been in past treatment, to starting buprenorphine, and how has your depressive symptoms reacted in that context? Okay, those will be clues. If they tell you I really get better within a week, that's a great sign. Okay, next slide. So what psychiatric symptoms overlap with OUD? Again, kind of for example. So these are things that, if someone that these are disorders where you're going to see overlap in either opioid intoxication or withdrawal symptoms. And so this is one way of looking at some mental health disorders that you might want to rule out. So we've talked a little bit about the overlap between depression and opioid withdrawal. We can see also some overlap between anxiety disorders, especially like agitation, worry. Lots of people use opioids to manage their anxiety symptoms. And so as they stop, you're going to see a potential spike, especially during withdrawal. And then even after buprenorphine, you'll see that those anxiety symptoms persist longitudinally to kind of indicate that anxiety disorders. PTSD where there's lots of anxiety symptoms, there's the hypervigilance, that sort of and the agitation. And then ADHD also comes up quite a bit within substance use disorders, and is good to definitely consider and rule out. We know that again, when people are not being treated for ADHD, their ability to kind of pursue treatment over time for their substance use disorders is diminished. And then antisocial personality disorder often is co-occurring in this population. All right, let's go to the next slide. So what are some psychiatric screeners that I would look at definitely incorporating into my SUD assessment? The PHQ-9, the GAD-7, the SID, the PC-PTSD this is the primary care PTSD screener, and then the ASRS, which is a ADHD screener. Many of these have been validated within a substance use disorder population, so you can start to tease out these symptoms using these screeners. They can kind of cut through the grayness to some degree. And you can kind of see the different links there. Okay, next slide. Some practical tips. Again, the PHQ-9, I would say this is good to assess at intake. Definitely gets that suicidality question, which is good to look at. And then I would want to repeat this in a couple of weeks to see how people are doing after they've had a chance to kind of get on a little bit more of a stable buprenorphine dose. Anxiety, I would do that as kind of a follow-up in a couple of weeks. The bipolar, I like the CID-3 versus the MDQ. It's a little bit more specific for bipolar, and so you're going to get you'll have less false positives. So if it is positive, that means that the patients have a higher likelihood of actually having bipolar. And then PTSD, of course, you can use this earlier in the diagnosis. There's lots of PTSD symptoms that kind of cut through a person that has a substance use disorder, especially around kind of flashbacks or that re-experiencing symptoms that people will have with PTSD. And then with ADHD, again, these symptoms are found to be kind of consistent across time points. So whatever people report earlier on, they often report later on when their substance use disorder is being treated. The thing with ADHD this is a developmental disorder, so people should have had these symptoms from childhood, and predate their substance use disorder. Even in the people that use early, like 10 or 12 years old, when they start using substances, they still had 10 or 12 years of untreated ADHD, which you can get to with history, especially if you have some collateral, which admittedly is not always easy to get with depending on their family history. Okay, next slide. So here's a few tips summary around depression. Relate lifetime course to use. So how does their mood hold up during periods of abstinence? Mania, this is going to develop whether or not people are using substance uses, and it's going to persist much longer than people that are using stimulants are going to see. Most of my patients that may have a binge episode of stimulants, they may go on for about 5-6 days. Many of my patients with mania from bipolar 1, they are manic if it's left untreated for months, and much longer than a person's going to be able to use stimulants on a consistent basis. Anxiety, this really kind of comes out after a withdrawal period. And then, of course, PTSD, we've talked about. There needs to be a traumatic event so you can get that history, and those intrusive and re-experiencing thoughts are key. And then ADHD, we talked about that as far as the developmental history. Okay, next slide. So even with all that, there's going to be cases where it's just hard to tell. And this is actually not necessarily specific for people with substance use disorders, but in general, there's a lot of grayness in mental health disorders, and you're going to need an ongoing evaluation. So, you may have you may do your initial assessment, you may develop your initial kind of list of different diagnoses you would consider, and then get some additional assessment over time, develop your working diagnosis, and repeat. Now, the thing that's great about kind of an integrated care approach is you can bring in other treatment team members to provide some insights into patients' symptoms and presentations in different settings and times And that's going to be very helpful to sussing out some of the more gray mental health symptoms and what those might be attributed to, whether that's a mental health disorder or if this is just kind of substance use disorder. Okay, next slide. All right. Okay, I kind of made those points. So let's go to the takeaways here. So in summary, assessing the physical, mental, and substance use symptoms in patients is important to support progress in whole person care. Again, the integrated treatment efforts are going to be more effective over sequential and parallel, although parallel, if that's what your system is able to provide, is going to be better than sequential. So there's kind of a hierarchy here. Mental health disorder diagnosis is an iterative process that may take some time, but it definitely is going to need to be done because it's going to impact your ability to effectively treat their substance use disorder. And vice versa. People are not going to be able to really get effective mental health disorder treatment or physical health treatment if their substance use disorder is not being addressed at the either. So that is it. I appreciate your time, and I will turn things over to my colleagues to kind of give you all a real life example of what this looks like.
Thank you so much, Dr. Duncan. And we do have a slide for questions, but instead of doing that at this time, we're going to move right on to our next presenters so that they have enough time. So I will go to your guys' first slide.
Great, and thank you again to all the MCO sponsors and to you, the attendings, for coming today. Appreciate the presentation that Dr. Duncan has given. We're going to try to pivot from his clinical expertise to a little bit more of the practice-based and programmatic response, and how we've humbly tried to take our experiences here at Peninsula Community Health Services to build our integrative program. So again, my co-presenters here, Bergen and Angie, will chime in. For the interest of time, we're going to kind of continue on through the slides here. You can go to the next slide, please. So just to give you a really quick overview of who we are, we're a federally qualified that does comprehensive primary care to underserved patient populations in the Kitsap and Mason counties, and soon to be the Key Peninsula as well. For those of you who are geographically challenged like I am, I have a little bit of a map there for you. So we're located directly west across the sound of the Seattle metro area in a rural/semi-rural area. I also wanted to give a little foreshadowing. This is actually the back of one of our mobile units that provides some mobile services. So this is subject to change, but this is where we are currently. Next slide. So currently, we provide a range of services through kind of the more traditional brick and mortar clinics, as well as kind of more innovative settings, including mobile, school-based, and et cetera. We provide care to about 30,000 patients per year. And again, this is just to kind of give you a background of the setting that we are. Obviously, we want to talk to you most specifically about our integrated behavioral health and substance use disorder program, and how a clinic system, in our setting, in our rural, semi-rural setting, was able to kind of achieve some of the integration that Dr. Duncan has spoken about, but also more importantly, this is an ongoing developmental process. So we also wanted to share some of the lessons learned along the way. Next slide, please. So to begin with, we really wanted to pair this with our mission and values of our agency. And I would argue that many of our agencies aren't too far away from this mission and value, given that we are in healthcare. So our effort was to provide comprehensive integrative care to our patients, and specifically starting to look at behavioral health and substance use disorder conditions through the lens, through a more medical lens, as a chronic relapsing condition that really requires kind of that lifelong longitudinal treatment, as Dr. Duncan had talked about. So our effort at PCHS, being a federally qualified, was really to provide that type of treatment in the community setting. Next slide, please. So I wanted to kind of start by talking about integration and our work towards integration kind of along a continuum. So anytime we're thinking about integration, we have to kind of consider that larger continuum. I'm starting with kind of the more traditional and evolving forms of care coordination. So as we're all probably aware, care coordination involves working with other agencies to develop these relationships in that we can we can care for patients across agencies, either sequentially in parallel, as Dr. Duncan had pointed out. So this is something that we do quite often at PCHS. This model, we've invested quite a bit of time, effort, and resources into developing a really robust care coordination workforce. So our workforce includes referral specialists, healthcare specialists, nurse care managers, community health workers, and many more that are involved in making sure that patients are attended to from one agency to another. This model also requires us to have very close and dynamic relationships with our community partners and other stakeholders within the community. So at PCHS, we worked really hard to work side by side with local hospitals, behavioral health and SUD facilities in our area, first responders, and like I said, a very wide and unique array of community stakeholders. So these are relationships that we've built over years of collaboration and education regarding, the need for coordination, which I would argue many of our stakeholders acknowledge and know is an issue, an ongoing issue, given the siloed nature of our community. So at PCHS, we have discovered, as I'm sure many of you have discovered, that even under the best of circumstances, there are substantial barriers to doing care coordination. So there's different hours, different phone numbers, staff that are acting as gatekeepers, transportation issues, physical space. In particular, we've had medical records systems disconnects and just the flow of information from one system to another. There's obviously service capacity issues, and that's particularly true in our rural, semi-rural area, and became even more true in light of the COVID pandemic, as some of our partner facilities had different hours and different capacities during that time. But really, even the differences in agency and sector cultures really kind of prevents that full integration and some of the efficiencies in workflows. So we've worked really hard on our referral process and our care coordination process. But I would say, for example, even under the best scenario and the best case situation, if one of our PCHS PCPs recognizes the need for mental health issues and is referring out to a community-based mental health agency, even with a well-partnered agency, we often require care coordination from both sides, from both agencies. We have to arrange and schedule intake visits, transfer of information, including ROIs and 42 CFR permissions. There are, like I said, redundant intakes, which are by very nature not very trauma informed when we're asking our patients and clients to repeat some of the traumas that they've had between different agencies. And then there's always the negotiation of who's responsible for which segments of a patient's treatment plan. Next slide, please. So this is just a funny example of what care coordinators look like. So we've had care coordinators for a while. Unfortunately, given the silo nature of our healthcare system, I don't think that the need for care coordination will go away in the foreseeable future, but this is kind of that good visual representation that without these care coordinators, without somebody to move people from point A and information from point A to point B, there are multiple opportunities for a call to be dropped or a patient to be lost along the process. So again, we at PCHS have invested a substantial amount of time and currently, even in our more integrated setting, we still invest a lot of time in those transitions from different levels of care, both in intensity and acuity. So for example, moving an individual who needs inpatient treatment or detox services from our community-based setting to one of those facilities and back to us again, really does require that care coordination. And again, the hope is that we continue the parallel treatment with the primary care while they are at those facilities, and we do coordinate sending prescriptions and other care through our care coordinators. But again, there is really always going to be a need for that care coordination across agencies. Next slide, please. So along that pathway and that continuum towards care coordination, we also have continued to work on the concept of co-location. So again, this is that idea of having a physical shared space to kind of strengthen our community partnerships and really encourage that warm handoff to promote that timely and parallel treatment opportunity. So at PCHS, we've partnered with a variety of community-based mental health facilities for some time now, and we've created kind of these on-site primary care facilities. We also have dental clinics on site that are able to offer some of the physical health, but also do some of the co-occurring substance use disorder through medications for opioid use disorder, as we'll talk about, as well as just kind of the low-lying behavioral health, mental health, medication management. This picture here is an example. So this is our Elmira clinic, which is located on the campus of Kitsap Mental Health Services here in Bremerton, Washington. Just a good example of how physically we can locate an area that's convenient and accessible to patients, as well as kind of promote that interagency dialogue. We've also developed co-locations at our school-based clinics, as well as in our county jails. So in all these settings, it really encourages that warm handoffs between agencies, and also kind of helps our agencies collaborate and quite frankly, get on the same page and develop that similar culture of integration across agencies. Again, this continues to be very resource intensive in terms of staffing and space, and Bergen, for one, can attest to this, that it does require that we are working very hard to make sure that we have the right staff in the right places. And for example, during the COVID pandemic, there was a lot of times where we had spent considerable resources negotiating the space in terms of the interagency policies and procedures and responses to the COVID-19 pandemic. So again, even under the best circumstances, having these co-locations still have its barriers. Walking an individual from one part of a facility to another part of a shared space does not necessarily guarantee efficient communication. In fact, we've had feedback from some of our providers in these co-locations that it's frankly more frustrating, that there is still a disconnect, even if we're in the shared space, that information doesn't flow as seamlessly across non-integrated records. And there is still the need to do a fair amount of care coordination and making sure that these shared treatment plans are indeed shared. To this point, and this is a topic for a completely different conversation, but PCHS has worked really hard towards health information exchanges with patient-centered consent to shares, so that, for example, in our Kitsap Mental Health Services partnership, that these information can kind of flow between our medical records. So there is some effort to do that. It's, again, just a work in progress and a challenge and a barrier. Next slide, please. So that kind of brings us to the collaborative care model. And this model is obviously the one that allows us to take the most integrated team-based approach to patient care. So again, this is not discounting the other models, as Dr. Duncan had alluded to. It's not that everybody can get to the integrated model, and it's not that we as Peninsula have gotten fully to the integrated model in all circumstances. We're really navigating the ways that we can utilize this continuum to make the best outcomes for our patients. But within the collaborative care model, we have incorporated more of the interdisciplinary perspectives into our shared treatment planning. So we have, again, as we had mentioned, our PCPs, our primary care providers, at the center of our patients' care, but we also have licensed mental health counselors. We have psych ARMPs that kind of do a little bit higher level medication management from the behavioral health perspective. We have a consultant psychiatrists on staff. Our substance use disorder professionals, which can do some of the, again, substance use disorder counseling. We have an addiction specialist, and then we've also incorporated some more of that care coordination staff to be part of the team, including nurse care managers, integrated care program coordinators such as Angie, community health workers, and myself as a clinical pharmacist even. So the idea is that the team identifies the priorities that, that are patient-centered, and then identifies which of those team members, or which group of team members are best suited to address the patient's needs. The other advantage of having this integrated collaborative care model is that we do have an integrated medical record. So we're very fortunate here at PCHS that we have the ability to see the whole person's care planning. So we have no break the glass behavioral health or substance use disorder segment of our medical record. It is all integrated, and people are able to see everything in the records, as are increasingly the patients able to see the whole spectrum of their records through their patient portals and other sharing options. So it really does help us with that collaborative care planning. We've also worked really hard over the years to develop common language and documentation standards. So I think one of the barriers that has been somewhat ubiquitous is that we have worked over the years as a health system to marry specialty practice with kind of the more primary care and overall practice. So there has been in the past differences and the need for almost translational services between substance use disorder professionals and our primary care providers, and vice versa. And so we've worked really hard on clarifying, for example, even recently acronyms. There's been quite a bit of use of LOC as an acronym, which can mean level of care for our treatment providers, may mean loss of consciousness for our primary care providers. It's just an example of how we're all collaborating with each other and really trying to calibrate our language so that we kind of understand that shared treatment plan. We also have shared documentation standards. So really learning what is the primary care provider really interested in this treatment planning. And then what is the substance use disorder professional or licensed mental health counselor? What elements are they taking responsibility, and what elements are they able to efficiently add to the conversation? So we all know that documentation standards are very robust and sometimes a little bit lengthy. And so being able to share that information in the most meaningful way has been something that has really helped our team as far as integration. Further, and kind of along those lines, we have common meetings among our entire staff. So anybody who's a provider, whether they're a substance use disorder, mental health provider, or physical health provider, we have combined meetings that really help us, again, calibrate that integration through our interdisciplinary discussions. So we'll have presentations by somebody who has a little bit more of a substance use disorder focus talking to the primary care, and we have our substance use disorder providers and people who have that scope kind of listening to what the primary care providers are thinking about when they're assessing the physical health of a patient. So it really helps us identify the needs of both sides of the equation and kind of come together and find where we have that shared common ground. And then finally, we have patient monitoring via population-based registries. So the idea here, and I laugh because I'm one of the people who doesn't love staring at rows and rows of Excel, as I'm sure Angie and Bergen can attest to. But really, these registries help us better monitor our patients in this integrated setting. So we really use these population registries to encourage follow-up, to encourage that longitudinal monitoring, to see what are the patient-centered interventions that people are receiving, and also more importantly, identify those system-level quality improvement gaps. So where are there gaps that patients aren't receiving the integration that they necessarily need? For example, recently we've been looking at our hepatitis C, where we've been referring to gastroenterology and more specialty teams, and we continue to look and see what that looks like as far as how we can integrate that within the services we provide. Next slide, please. So again, just a little bit of a busy but graphical representation of everything we're looking for. This kind of parallels what Dr. Nucken was speaking to previously. So in green, we have things that are more traditionally viewed as the physical health side of things versus the blue being more the substance use disorder and behavioral health side of things. And so really, we've tried very hard to marry those together in our integrated setting. So again, as Dr. Duncan had pointed out, we do quite a bit of screening in terms of depression and anxiety. We do that early and often and longitudinally, and it's really interesting to see longitudinally how, again, people who are struggling with substance use disorders, how their overall sobriety impacts these screenings, and on the flip side, how getting treatment for depression and anxiety in general for our patients and that whole person care also helps those screenings. We often have the conversations with providers when they notice that those changes, and they wonder whether or not it's the substance use disorder side or kind of more the mental health side. And I would argue that it doesn't really matter, that it's a little bit of both, as Dr. Duncan has argued. It is very much an overlapping thing. And so we're really seeing that married in our primary care setting. We have that assessed early and often. We've actually even move that on to our dental and our oral health setting. So Bergen has been fortunate enough to speak with our dental staff and have our dental providers actually providing some of these screenings within their dental visits and referring if there's suicidal ideation or other more crisis interventions or early interventions that can be made. We have SBIRT, so that screening, brief intervention, and referral to treatment, and we've been using that for quite some time. Again, that allows us to do early intervention and referral, but it just generally opens up the conversation for additional assessment. It also reinforces the idea of this integrated SUD program expansion as more and more of our PCPs see the need within their own patient population as we screen for SBIRT. And then, as we were talking about before, we also realize that we all have limited timeframes. I know that's not a surprise to anybody, but time constraints is going to be one of the real issues that we hear across the board, regardless of the provider. So having the ability to do different types of assessments and kind of triage kind of the longer substance use disorder, getting those histories and the mental health histories in a larger than a 15 to 30-minute visit that some of our PCPs are afforded, really allows us to communicate back and forth. We do urine drug screens, which I would again argue informs both sides of the houses in that there are a lot of confounding and contributing potential to those differential diagnoses, as Dr. Duncan had pointed out. So really identifying if what we're seeing in front of us is substance induced, if it's withdrawal induced, or if it's kind of more organic in nature. This kind of helps us tease it out. On the physical health side of things, or what we traditionally think of the physical health, even just going down to vitals, we realize that weight, blood pressure, a lot of these things are influenced by either behavioral health or substance use etiologies. We do comprehensive metabolic panels, which again points to us whether or not there's kidney or in this setting, liver dysfunction. Complete blood counts help our providers identify if there's infection or anemia, again related to substance use disorder. We do the hepatitis screenings, the HIV screenings, looking for other sexually transmitted infections or endocarditis, all again related to the context of the whole person. More importantly, as a federally qualified, we're obligated through our accreditation to look at preventative screenings, vaccine screenings, family planning, oral health, and just general medical history. All things that I would argue a lot of patients that have mental health and substance use disorders have previously been underserved by, just by the nature that there is a lot of stigma both ways, and the idea that individuals that have these disorders may have been underserved by the healthcare system in general in the past by being labeled as users or labeled as drug seekers, and I'm putting those in quotation marks because I know that they're not very trauma informed, but that's the reality, is that we are seeing a lot of patients that come to us perhaps for substance use disorder or mental health, but really in effect get the whole person care because we're now able to address the other screenings and other factors. Next slide, please.
Albert, I just wanted to let you know that there's about 5 minutes left.
Yep,
so,
perfect.
Okay.
Thank you for that.
Yep, no problem.
We're going to go through the last slides, kind of that sets up the last few slides. So this is a brief history, and this is my intent, is not to put you to sleep with this brief history. So this will be just kind of where we went with what we have talked about so far. So in 2011, about a decade ago, we have really committed to integration. And again, we built on our mission and values to make that case. And I would argue that any of your agencies can do similar. Just like any change process, we had to identify those practice champions, and we've been very fortunate to have senior leaders that are very invested in this issue. But we also had a lot of early adopters in practice, both from, again, the traditional substance use disorder mental health provider standpoint, and also among our PCPs. We approached this humbly and realized that we don't have all the answers, nor do we still. So we have pursued and continue to pursue technical assistance through those agencies listed below. I would highly recommend, if you're not familiar with these resources, to review this at your own leisure. And then we continue to plan for implementation and sustainability of our programs. So really thinking about those low hanging fruit and kind of that incremental iterative process of how we build out the program. Next slide, please. So in implementing our program, we again developed that integrated workforce and started really working on getting the personnel in place in 2013. We really used those validated screens, as we pointed out before, to highlight the need and kind of make that case to our provider or existing provider team that, hey, this need is among us, both from the substance use disorder side, but also from the co-occurring disorder side. We've worked on those trainings, so again, those monthly meetings, really focusing on issues of trauma-informed care, stigma, and harm reduction. And then we've really developed those policies and procedures to kind of make the case for the workflows that we're implementing. And we put them in relatable clinical terms that I think our primary care providers can really relate to. So one of the caveats that I like to share most frequently is paraphrasing from Dr. Fortinos, our HCA Deputy Chief Medical Officer, that she really likes to point out that the morbidity and mortality reduction with the use of methadone and buprenorphine can decrease as much as 50% the mortality among individuals receiving this treatment. And she likes to compare that to the statins and blood pressure medications that we use in primary care in general. Usually those are in single-digit reductions, even over years of medication use. So that really kind of hits home to our providers that, you know, again, this is something that's worth doing, and that we're in the business of saving lives. This is a great way to do it. Next slide, please. So we've really built upon that initial change. We've implemented our medication for opioid use disorder, or medication-assisted treatment as it was formerly known. We've implemented some of the psychosocial things, again, using that evidence-based treatment. Next slide. We've continued to update our policies and workflows. So we really started with kind of more restrictive policies and procedures, having people go through steps, including seeing an SUDP first in our initial iterations of this, to getting to the point where we're now considered low barrier harm reduction. We actually have 2 o'clock or 2 p.m. slots open for same day visits for our PCPs. Now patients are routinely induced in the same visit that they're doing their general intake, while we're also addressing behavioral health concerns and their physical health, all in the same thing. And we've developed the macros, the templates, and other things to kind of help our providers work along this continuum, including the screenings that were discussed earlier. And then we've developed those monitoring and treatment adjustments, including the registries, to kind of help inform and support our providers. Next slide, please. So again, we've added the innovative services. So having that no wrong door approach, and finding different ways of getting people into this whole person care. Next slide. Interestingly enough, we've also even done syringe exchange within our pharmacies currently, which helps us bring more individuals into our services. And this really highlights our wraparound services here, that we have recovery support, we have our peer specialists, we have community health workers that are, again, looking at that whole person care and developing those, or working on the social determinants of health, including housing and transportation. Next slide, please. And then COVID has really forced us to show the robustness of our program and demonstrate the stability. So we've, at PCHS, had 10% of our workforce allocated in the last year towards testing and vaccinations. So we've really had to work at how we approach this in team-based care, and with the workforce that we have in place. There's been quite a bit of turnover, as I'm sure is not unique to us. In that time, we've also kind of expanded our telehealth to maximize our reach. So we've really worked at how we can make this co-occurring and this integration work within the challenges that present to us. Next slide, please. And then going forward, we really want to focus on this integration within training. So you'll see some of the training programs that we have developed. The idea here is really that we can start this concept of integration early on in an individual's development and training. So you'll see some of the training processes that we have in place at PCHS that we're kind of proud of. And we really want to emphasize that this integration exists and it can work in practice. Next slide. So this is just kind of a cute slide of one of our mobile programs. I just wanted to really quickly share in the last a little bit over here, but one of the best examples that I have is one of our mobile health providers came running to me, actually, frankly, in a gas station as I was pumping gas for my own personal vehicle, and was really proud to tell me that he had an individual who came and established care for a physical health visit. Turned out that the patient was a patient who is currently on methadone treatment, was traveling from Port Angeles, so one side of our state, all the way to Seattle to get an opioid treatment program. Realized that we had mobile services, was able to reach these mobile services. His proudest moment was not only that she established and was doing well longitudinally in our substance use disorder program, but she herself got all the routine screenings, but more importantly, her daughter got all of her screenings and had not been seen by any physical health previous. So I wanted to really use that example to highlight that this isn't only whole person care, but it's whole family care and whole community care as well. And then next slide, final slide. So these are our takeaways. I think we've talked about it. This is something that I would highly recommend, and from a programmatic standpoint, that we really did do the incremental change. And again, we're not all the way there ourselves, but really want to emphasize that continuum. That's all I had. Thank you. Thank you.
Thank you very much. Sorry we went a little bit over. We are definitely willing to accept questions though after and as you fill out the survey. Please do add those. And if anyone wants to stay on for a little bit and ask some questions in the chat, we definitely can respond to those. So I know our list of attendees has dwindled a bit, but we're definitely willing to answer any questions for just a couple minutes here. I didn't see any in the chat. Did you, Lindsay?
I did not. There was a question around the presentation being emailed. I wasn't sure if we were able to send out a PDF of the slide deck to those who participated, but I do believe we'll have the ability to share the recording following the webinar.
Yes, and maybe even those that are registered, we might be able to send it out, but we'll see if we can do that for sure. But we will definitely be sending the recording of this so you can share that. Okay, well, thank you everyone for joining us, and we conclude our training today. Thank you, presenters, for your time.